For coming. My name's Kevin Heaton. I'm a sports medicine physician. I work at Mobility Bone and Joint. We have three offices: Andover, Salem, New Hampshire, and Haverhill. So I work exclusively at the Haverhill office, and I've been there for 4 years. So I'm going to be talking about platelet-rich plasma. We call it PRP, so we don't have to keep saying that over and over, but that's what it is. Platelet-rich plasma. We call it PRP for short. This has been used in orthopedics since the early 2000s. I've been using it in my practice for the last 14 years. And it's become more and more accessible to the general public. When it first came out, this was like used exclusively for like professional athletes. You'd hear stories about, Tiger Woods was getting it and all this stuff. But now it's become much more mainstream and accessible to everyone. So I think it's timely at this point. So my goals for today, go over the definition of PRP. How does it work? How do we make it? What do we use it for? And what are the alternatives to PRP? So the definition. So this is a medical treatment. It involves the injection of a concentrated solution of a patient's own platelets into an injured or damaged area. Okay, so we're taking high concentration of platelets and injecting it. Why do we do this? We do this because platelets, they release growth factors, proteins, and those stimulate the repair and regeneration of tissues like tendons, ligaments, muscles, and joints. So the concentration of the platelets and the growth factors is important. Ideally, it's 5 to 7 times above what you would see in normal whole blood. Okay, and this is important because not all PRP is created equal. There are some products that are claiming being PRP, but they're not reaching the concentrations even close to that. So, not all PRP is created equal, I'd say. All right, so we're gonna do some math. Okay, we're gonna count platelets here. So if you were to go and get your platelet count checked, as I'm sure we have all done, it's in your regular CBC, tells you if you have anemia, they'll check your platelets, and you'll usually get a number between 150,000 and 350,000 platelets, okay? That's how many platelets are in a microliter, okay? So let's just assume we have a sample patient who has 200,000 platelets in a microliter, okay? A microliter is incredibly small. There's 50 microliters in 1 drop of blood, okay? So we're going to change that unit, and we're going to change it to a milliliter. And a milliliter is what we're used to using in medicine. So if you think about what is a milliliter, okay? That is a milliliter, okay? So that's a milliliter right there. So there's 1,000 microliters in a milliliter. Okay, so then we're going to start doing some math. So if you take 200,000 platelets times 1,000, that means 200 million platelets are in 1 milliliter of blood. And if I'm going to do a PRP, say to your knee, I'm going to draw 60 milliliters of blood. That's 12 billion platelets. Okay, so that's the type of concentration of platelets that we're talking about injecting when we're doing this procedure. 60 milliliters, by the way. You're going to say, how much blood is that? This is 30. So we'd be taking 2 of these if we were doing a knee. If I was doing a tendon, a smaller tendon, I would be taking just 30. Okay, so this is a 30 milliliters. Okay, so how does PRP work? So if you want to understand how it works, really you're just reviewing how does normal musculoskeletal injury heal itself. The platelets' main role, why do we want platelets? That's what we're trying to concentrate. So we're trying to concentrate them because a platelet's main role is to prevent, stop bleeding, and tissue healing. So if tissue is injured, generally what you're going to have is you're going to have a repair response. You're going to have a blood clot that goes to the damaged tissue. And the clot's going to be red blood cells, the big red circles. It's going to be platelets come and stick and make it sticky. And then this yellow is like fibrin. It's like glue, keeps it all there. Then once that happens is these platelets, they do what's called degranulation. It just means they release growth factors and other proteins all in that area. And what that does is it's basically a chemical messenger. And it says, hey, we want pro-inflammatory cells to come to this area. We want stem cells to come to this area. In particular, something called a mesenchymal stem cell. So mesenchymal stem cells are stem cells that are found in bone marrow. And why we like them is because they can differentiate into many different types of tissue, okay? Bone, cartilage, muscle. And so obviously they're very important for repairing damaged tissue. So basically when you ask, how does PRP work? It's just trying to stimulate, augment the normal healing response and just magnify it. That's what we're trying to do. And so, we're not doing this usually in acutely injured tissues because you let your body do the whole thing. You let the body try to repair itself initially. So this is usually done for things that never healed correctly, something that's chronically injured that never fully healed, okay? So growth factors. So we don't need to go into all of these, but for your reference, whole bunch of different growth factors. These are the ones that are identified in PRP that seems to help. And this, again, promotes tissue regeneration and then upregulation of collagen synthesis. Collagen is the major protein in skeletal tissue. So if you're trying to rebuild something, you need extra collagen to that area. And so these growth factors tend to increase the amount of collagen that goes to an area. All right, so on to how do we make it? So we need blood, we need the kit, and we need a centrifuge machine. So before we go into exactly how we do it, I'll show you a video. We're going to go into what is in whole blood because we need to separate it, okay? So in whole blood, there's a few things. There's red blood cells, there's white blood cells, there's platelets, and then there's plasma. And think of plasma as just the water that everything's floating in, okay? And each of these has a different weight to it. So if you put it in a centrifuge and you spin it, everything's going to separate out into different levels, okay? And so this is very helpful to us. So we can basically spin it down, separate it. We can pull off the components that we want. We can discard the components we don't want, okay? So if you look at the tube to the right, you'll see it has been spun. And now the layers are all separated. And so what you'll see at the bottom, those are the red blood cells. They're the heaviest, so they go to the bottom. In the middle, it's called a buffy coat. But what that is that is all the white blood cells and the platelets. So they're right in the middle. And then on the top, the lightest is the plasma. And again, just think of that as being almost like water, okay? Once I have my first spin, it's going to look exactly like this, okay? So then what I'm going to do is I'm going to take out this top layer, okay? I'm going to completely take it out with a syringe. I'm going to leave the red blood cells, and then that gets thrown away, right? Then I'm going to put it in the second container, and I'm going to inject it back into the second container. And then I'm going to do a second spin. And at that point, all the red blood cells are gone. So what's the heaviest in there? There's only two things left in there, the plasma and the platelets. So if you spin it down again, the platelets are actually now stuck to the bottom of that tube. So then what I'm going to do, I'm going to decide how much volume do I want. Say I want 5 milliliters. I'm going to take off the top 5 milliliters. The platelets are all stuck at the bottom. And then I'm going to have 5 milliliters of just plasma, which is water. The platelets stuck at the bottom. And I'm going to just shake it to release those platelets. So it's now suspended in that. I'm going to draw that up into the needle, and that's what's going to be injected into the patient. Okay. So 2 spins in a centrifuge. And at the end, all you'll have is plasma and then that very high concentration of upwards of 12 billion platelets suspended in that. Okay. And generally it will be yellowish, maybe a little tinge of red with a couple leftover red blood cells, but not many. Okay. All right. So the nice thing about the type of kit that I use, which is called M-Site, is you can customize the PRP because I might want a different type of PRP depending on what I'm treating. Okay, so there's two types of PRP. There's leukocyte rich and leukocyte poor. So leukocyte rich, a leukocyte is a white blood cell. Okay, white blood cells are usually pro-inflammatory. So if it's leukocyte rich, the concentration of white blood cells is going to be higher than normal blood in that. And we actually like this in some tissues because we think certain tissues like muscle, tendons, ligaments do better with more inflammation to try to heal. And so in that case, leukocyte rich PRP would be helpful. And so if I'm doing that, what I'm going to do is I'm going to draw off that entire level of plasma. I'm going to take that buffy coat. And then for leukocyte rich, I'm going to take a very small little portion of red blood cells. And the reason is because I want these neutrophils, and the neutrophils sit right on top of the red blood cell, literally like right on top of it. So if I take a little bit of red blood cells, I know I got all the neutrophils. Okay. And so this gives me leukocyte rich PRP. And again, this is for soft tissues. Okay. So tendon, ligament issues. I'm not putting leukocyte rich PRP into a joint. Right. So leukocyte poor. So obviously this has the same or lower number of leukocytes. Leukocytes are white blood cells. We have two names for everything just to make it hard for everyone. Okay. So they have lower than average numbers of those. And so this is less inflammatory. So if you're doing a joint, you do not want a big inflammatory reaction in a joint. It's thought to be irritating to the cartilage. So you might be doing harm, irritation to it. So for joints, we try to always do leukocyte poor. And for this, we would take the plasma and that buffy coat layer, but we would make sure no red blood cells. So you're avoiding those neutrophils. You don't want the neutrophils. Okay. So less inflammatory PRP. Okay. So we're on to what do we use PRP for? So the number one thing I use it for is osteoarthritis. Osteoarthritis is a degenerative process of joints where the cartilage is worn down, which leads to pain, swelling, bone spurs. And so it is quite frequent that we would do this PRP for the knee, hip, and shoulder. Okay, those are the biggest, large joints that people have that typically I would inject PRP into. Theoretically, you can do it into any joint, but again, you're trying to concentrate a high amount of platelets, so it might be hard to do, PRP into like a finger joint per se, because you might not be able to concentrate enough platelets to actually make it worthwhile. So we also use it for soft tissue injuries. So some examples of this is hip bursitis. Okay, a lot of people have hip bursitis, pin on the outside of your hip. The term bursitis is a little bit of a misnomer. So rarely is it really bursitis. It's actually a form of tendinitis. Okay, you have glute medius and minimus tendons that attach to the side of your hip. And so we use PRP for that. The rotator cuff. Okay, those are the tendons that help control movement of your shoulder and elevate your shoulder. So if someone had chronic irritation of the rotator cuff or a partial tear of the rotator cuff, could be helpful. If you have a full thickness tear and the two ends are far apart from each other, PRP is not going to fix that. Okay, that needs surgery. Okay, so you're looking for small tears, partial tears, chronic irritation for rotator cuff, that would be helpful. Achilles tendon is a common tendon that can have partial tearing and inflammation that PRP can be helpful for. And then plantar fasciitis. So this is pain on the bottom of your foot. PRP also has been shown to be quite helpful for that. So some issues, this is generally not covered by insurance. Okay. So that's the downside. I've had a few cases where workers' comp might cover it, and I've seen only one insurance called TRICARE. It's a military insurance. I've seen that they have covered it. Any other insurance, I've never seen it covered. So generally not covered by insurance. The cost ranges between $500 and $25. It's a big range, okay? It depends on what kit you're using. $500 overhead of your practice, and a lot of times the part of the country you're in. Some places is frankly more expensive than others. You know, you go to New York City and get it, you're going to pay twice as much as you may pay somewhere else. You might need more than one treatment. So some of the studies that showed it was helpful used a single injection. Others used 3 injections, which could be a week apart, 2 weeks apart. So the way I practice is I do a single injection and then I reassess, usually after 12 weeks, and decide if I should do a second. I just can't justify the cost of 3 right out of the box when 1 might do the job. So generally I do 1, reassess, do a second if I need to, rarely a third. Okay, but on some occasions that has been, I have done that. And again, this isn't usually necessarily first line treatment, right? So if someone comes into me, I've had a week of pain in my hip or my elbow, I'm not saying, oh, let's do PRP. You know, you're doing the other stuff first, usually anti-inflammatories, therapy, you know, all the rest of the stuff. So it's not like we're super aggressive at using this. This is usually for refractory cases of pain. So non-orthopedic uses. So aesthetics and dermatology. So they use it for hair restoration and skin rejuvenation. In dentistry, it has been shown to enhance healing after oral surgery. And it's also used for wound healing for chronic wounds that just won't heal. That's another non-orthopedic use. So alternatives to PRP. So like I had mentioned, you know, PRP is usually almost last on my list of things to do. Usually we're trying physical therapy, oral medications, braces, cortisone injections, synthetic joint fluid injections, which is a gel, a lubricant that we might inject into an arthritic joint, okay? And then shockwave. Shockwave is another type of regenerative treatment where we use high energy sound waves to stimulate tissue to try to get it to repair itself. So a little bit similar to PRP, but done in a different way. So I'm going to talk a little bit about cortisone injections because we do them frequently. And in my mind, it's almost like the anti-PRP. So I just think it's kind of interesting to compare and contrast. What would you get out of cortisone versus PRP? And I do cortisone injections all the time. So I don't have anything against them, but you have to understand cortisone injections are a very strong anti-inflammatory, whereas PRP is pro-inflammatory. So cortisone is just trying to calm down any inflammation, take away pain, but it's not aimed at healing a structure or regenerating a structure, okay? So cortisone injections has short-term side effects. You can get what's called a cortisone flare, which is for the first 24 to 48 hours, you're not happy with whoever gave it to you. You're saying, why does this hurt more? Okay, usually goes away after that. You can get thinning or discoloration of the skin. So this is an elbow. This is someone who had tennis elbow and they got a cortisone injection. And you can see how their skin is discolored, okay? This may be permanent. It usually fades over time. And they've actually done studies that show PRP can help reverse this, which is interesting, okay? And an increase in blood sugar. So this is particularly worrisome, cortisone injections in diabetics, particularly poorly controlled diabetics on insulin. So if someone comes to me, wants a cortisone injection, you know, well, the first question I'll ask is, do you have diabetes? And then I'll ask, what's your hemoglobin A1C, which is what their average blood sugar is. And if it's elevated, I'm saying, no, I'm not going to do it because I could send you to the hospital for elevated blood sugars. So that's a major downside of it as well, which you don't have that problem with PRP. One of the other things we see is if I inject cortisone into a joint and then you need to then go on and have that joint replaced, your risk of infection is higher if you have that knee replaced within 3 months, okay? So if I inject your knee and then it doesn't work and a week later you go to the knee replacement surgeon, he's going to say, sorry, we're waiting at least 3 months. Otherwise, you might get an infection in your knee and then we're really in trouble, okay? So long-term issues with cortisone injections, usually with repeated ones, cartilage damage, so particularly in a knee, okay? So when we're injecting a cortisone injection, 2 things are going in. The cortisone, which is the steroid anti-inflammatory, and lidocaine. Both have been shown to be relatively toxic to cartilage. Okay. So while it will calm it down, it will make it feel great. If you do it over and over again, you might actually make someone's arthritis worse over a time period than they might have had otherwise. So do I do cortisone injections to the knee? Absolutely. But I tell people this is not your solution. Coming in every 3 months to get cortisone injections into your knee, not the solution. If your knee's killing you, you have arthritis, you're going to Disney World in a month, and you want something to calm it down, fine. But the long-term solution for arthritis is not cortisone injection. Injecting it around tendons could weaken the tendon and cause rupture. Okay, so that's another thing that we worry about, particularly with around the Achilles, the patellar tendon. These are tendons that have a high amount of energy and force put through them. And so there is that worry that if we keep injecting around a tendon, it weakens, it pops, and then all of a sudden you need surgery. Okay. Steroid can also cause local bone thinning, osteoporosis around where it was injected. Oral steroids, when you take it via pill, that can, affect all of your bones, but locally it could affect some of the bone structure right around where it was injected. Okay, so rare but serious risks of cortisone, allergic reactions. This is pretty uncommon, but it can. Joint infection. So anytime you do an injection into any joint, there's a potential risk of infection. They've done some studies with cortisone and showed that maybe 1 in 10,000 injections could become infected. This is 0.01% of injections lead to infection. So listen, it's rare, but theoretically it could happen. And this is a bigger one. Now, this isn't super common, but something called avascular necrosis. So avascular necrosis is where you inject into a joint, and that leads to loss of blood supply to the joint, and the bone basically collapses. Okay. So this is an X-ray of a right hip with avascular necrosis. You'll see this is a normal hip, a nice round ball. Okay. And then if you look at that one, it's completely misshapen. Okay. It's flat. It's completely just collapsed. So that's avascular necrosis of the hip. There are some studies that show it could be as high as 5% of injections into the hip lead to avascular necrosis. Most do not show it's that high. They show it's less than 1%, but it's definitely more prevalent in the hip than it is other joints. Almost never see it in the knee or shoulder, but the hip is the big one where I really caution people, say, hey, you have to be careful about this complication, because if that happens, you bought yourself a hip replacement. That joint needs to be replaced. All right, so other issues with PRP. So some medications can interfere with it. So it's important to let the doctor who's treating you with it know about all your meds and even supplements, right? Because there's some supplements that are highly anti-inflammatory, and those might counteract some of the PRP. For the same reason, we want people to avoid NSAIDs. So NSAIDs are ibuprofen, Motrin, Aleve, that type of medications, meloxicam, aspirin products. All of those are anti-inflammatories. Okay. So if I'm doing a pro-inflammatory injection and I'm trying to get this whole chemical cascade to repair this structure, and you're taking an anti-inflammatory, you're stopping it. You're telling the stem cells, don't go to that area. I just want to calm down the inflammation. So we usually have people stop the anti-inflammatories for a week before the injection and 4 to 6 weeks after the injection. And then the other thing for people to know is it's not like a magical shot. Like if you have Achilles tendonitis, I just injected in a week, you're better. It's basically, I tell people, we're restarting it as if you just injured your Achilles, and we're going to start it over with a brand new healing response that has extra platelets in it. But it's still going to take time, a couple of months, and therapy oftentimes will be helpful to help it go back to normal. So not a magical injection. Still, usually for soft tissue, I'm recommending physical therapy. There's specific rehab protocols we do after PRP. Usually for the joints, not so much, because it's in a joint and you're just kind of, there's not a whole lot of therapy to be done for that. But for the soft tissues, there usually is physical therapy involved after the PRP injection to maximize its efficacy. So contraindications, when would I not use it? If you had a terrible systemic infection, so you have bacteria circulating in your blood, not a good idea. If you had a local infection around where I would want to inject, I would not want to do that. If you had some syndrome where your platelets were dysfunctional, were not working correctly, you'd say this is probably a waste of your time and money. Severe thrombocytopenia, that's when you have very low when you have very low platelet counts. So if I want your platelet count to be 200,000 per microliter and you come in and yours is 40, what I'm saying, you're probably wasting your time and money. So don't do it. If you have active cancer or hematologic malignancy, which is like blood cancer, don't want to do it, right? I wouldn't want to concentrate cancer cells and then inject them somewhere else in your body. Not a good idea. And then anticoagulants. So if you're on like Coumadin, Xarelto, meds like that, then if you can't come off them due to safety reasons, then maybe this is not the right treatment for you. So questions. So I'll take questions now if you guys have questions on it. Yeah.
Is this in place of a knee replacement? Like if my knee is already bone on bone?
Yeah.
And they don't even want to do cortisone anymore or the gel shots. They don't think it would make any difference.
Right. Yeah. So it's a good question. This comes up all the time. So the studies showed that PRP was best with mild to moderate arthritis and worked less in people with very severe arthritis. Okay. So I generally tell people, if I look at an x-ray, I talk more people out of PRP than I talk them into it. Because sometimes I have people come in, I look at their x-ray and it's like, there's 3 compartments of the knee, inside, outside, and underneath the kneecap. Sometimes people come in and it's like all 3 are bone on bone. And they're like, well, what about PRP? And I'm like, you're probably wasting your time and money. I mean, some things, there's no amount of treatment that can help that. So would I offer it to someone if they had no other surgical options? Yes. So for instance, someone who says, I can't get surgery because of some other medical condition, my heart, stroke, something else, I would offer it to them. But if you had very severe arthritis, and I would want to look at the x-ray, right? Is it really bone on bone or is there something there? So there's some caveats to it, but if you had terrible arthritis, I may talk you out of it and say, yeah, it's probably not worth it. Whereas if you had mild to moderate arthritis, I might say, yeah, you're a good candidate. Does that make sense?
Yes.
Yeah. Yeah.
So I've heard of regenerative stem cell therapy. Is this different?
This is different in that the stem cell therapy is trying to directly concentrate the stem cells, harvest them, and inject those directly into the structure. Okay. So it's obviously more invasive, right? So you have to collect the stem cells, which typically involves a bone marrow harvest. So they're going to go into your pelvis bone and they're going to harvest it out. Or they're literally going to do liposuction and they're going to harvest the stem cells from your fat in your abdomen. So it's more invasive. The cost skyrockets. And I'm not sure that the outcomes are a lot better. So I hate it so I would usually say, if you're going down that route, why wouldn't you try PRP first? And I would say the same thing to your question about if I have bone on bone arthritis with that, it's the same thing.
Yeah.
It's not going to turn a knee that's bone on bone into a normal looking knee. It does not reverse. At best, it might slow or increase density of the existing cartilage by like nanomillimeters, right? They've done some studies that showed maybe on MRI, it might have increased a little bit. But so it's different. This is kind of the precursor to this. So you're basically saying, tell the stem cells to go there, whereas they're directly harvesting them and injecting them there. So the response would be theoretically better. But I think you'll find there's been more studies on PRP than that. And, I'm not sure that they're a whole lot better. So, and I would still say just be cautious. If it's terrible, terrible beyond repair, you're probably wasting your money.
Yeah.
And the cost of a stem cell treatment could be 5 to 10,000 more. It could be 15. So I mean, you're talking real money, right? So sometimes I see people, frankly, get taken advantage of, where they come in and they say, I got all this done at QC Kinetics, and I say, well, okay, I might have told you that it probably wasn't going to help based upon what I'm seeing. So they're different, but they're still trying to harvest the body's reparative response, just in different ways.
Yeah.
Other questions? At the time of a knee replacement?
Over the shoulder knee,
A replacement, no, because you're completely removing that joint, and there's no longer any arthritis, is irritation of that articular cartilage. When you get a replacement, that's completely gone. So now it's metal. And so there's no benefits of doing it at the time of a replacement because it's there's nothing else to treat in there that would help.
Regenerate any.
No, because you decided at that point, I'm replacing the tissue. So the other to tell you where it may be more relevant is, could it be helpful at the time of rotator cuff repair? So they're taking a rotator cuff, they're sewing it back together. What if you put PRP in that? Would it augment that repair? So there's maybe more promise with that. But the problem is, at the time of surgery, they're washing it out continuously with saline to open up the joints. So if you inject it in there, you're probably just washing it out at the time. So they're trying to develop almost gels or pastes or that you could stick on it that have PRP that would actually stay to help, but not at the time of joint replacement. Yeah.
Yeah. You were talking about full shoulder, full thickness tear versus a partial tear.
Yeah.
I have a partial tear. I've had it for 10 years.
Yeah.
And I just can't go over the head with weights, but I can normally lift weights. But it's a roller coaster. It gets irritated.
Mhm.
It's time to go back to the physical therapy.
Yeah.
Till that pain is gone, then I can get back to working out the shoulder.
Yeah.
As far as a partial thickness tear, will that heal?
There might be a role for it. So you have to say partial thickness tears come in many different sizes. So there are some partial thickness tears that almost could be called a full thickness tear. There's a couple fibers left, and there might be some retraction, versus a partial thickness tear where the ends are very close together and you think that the PRP might actually be able to bridge those. So it would be important to see the actual imaging, and or oftentimes I would ultrasound someone, because I can use an ultrasound to say, and then usually I could give someone a good opinion on whether I thought it was worthwhile. But a partial thickness tear, yes, the role of PRP is to try to heal that.
So it would have to be evaluated.
It would be evaluated. That way I could give you a sense and say, that's really more a full thickness tear with retraction and there's just too much space between the ends, or no, it could be helpful. Oh yeah, absolutely. So the research, the insurance companies keep saying that, like, oh, it's experimental, so there's no research, but there's a ton of it. And so I think this is going to be posted online, but there's one. I emailed the guy to see if I could use the slide, and he said no, he wouldn't let me use the slide. There's a guy who does regenerative medicine, and he put there's one link, all the studies for PRP for everything, and I can include the link to it. He just wouldn't let me put the slide on it. There's a lot of data comparing it to placebo, saline, visco supplementation, cortisone injections. So yes, it's out there for soft tissue and arthritis. Yep.
So this
saying, what is insurance companies?
Money. Money.
No?
Money. They don't want to pay for it. They don't want to pay for it. They don't want to pay for anything that they don't have to. So they're at this point, they continue saying it's experimental. We don't have enough data, you know, and they don't want to go there. Well, for orthopedic uses since the early 2000s. So, I mean, it's been routinely used for 20 years. The issue is the higher quality studies didn't start back then. So do we have 20 years of good high quality studies? No, we don't. So the higher quality studies are in the past 10 years. But the insurance companies still don't seem to want to go there. Yeah. Yeah. Sure.
Question. Somebody with mild to moderate arthritis, if they have this done, whether it be 1, 2, or 3 injections, does that mean they'll never need a replacement down the road, or will just hold them on long?
Yeah, no, it's definitely not. There's no guarantee that it would prevent the need for replacement. So I tell people, if we all live long enough, our knees are going to go and we're going to need replacement, right? And so based on genetic factors, some people are more likely to develop arthritis no matter what they do. And so PRP is no guarantee of avoidance of a knee replacement. It is designed, in my mind, to decrease your discomfort and to prolonged use of that knee and put off a knee replacement. And depending on your age, that could be indefinite, right? But if you're 30 and already have moderate arthritis and you already are at the point where you need PRP, I'm saying do PRP until you're 50 and then get your knee replaced, because no one wants to get a knee replaced when they're 30, right? Because then they're going to have to get a revision. So oftentimes it may still be a temporary solution to a problem that can only be fixed by knee replacement. But I would not advertise it myself as a solution. You do this, you'll never need a knee replacement. There's just too many factors involved. Yeah. Yeah.
Can you do this a couple times?
That's not a routine use of it. Are there some like cowboys that are doing it for it? Yes, but no, that is not a routine use for it.
Just say is the most common use or
Knee arthritis.
just.
Knee arthritis and
That's
tennis
low-
elbow.
lower. That's only lower to moderate.
Right. But that knee arthritis is the most common arthritis that people have. Therefore, that's the most common that I do.
Tendonitis.
Yeah. Then so it's knee arthritis, and then it's like tendonitis of the elbow. Those are the two most common that I use.
PRP can't stimulate the regrowth of cartilage. Can it?
Yeah, that's the point of what you're trying to do in a knee. But like I said, it hasn't been shown to like take a knee that's bone on bone, and then all of a sudden you're like, oh wow, it looks like a brand new knee. So you're trying to decrease pain. So it's shown to decrease pain, prevent progression, right? So if you can have less pain and it doesn't get worse, that's what I'm telling people my goal is. Not to say, oh, you're going to have a knee that looks brand new. But yeah, it's part of bringing the stem cells there is that it could start stimulating new cartilage growth. It's just at some point, it's not enough to make a knee look normal or perfect. Yeah. You can inject it directly into a meniscus to try to help that heal. Yes, that can be done.
They use this with microfracture too, you know, trying to re-stimulate cartilage growth. I mean, it's something that injection with that.
You could, most like don't, but you theoretically could. But their argument would be, yeah, I'm already stimulating enough. That's the whole point of it, is stimulating enough, bleeding in that area. So you might ask the question, are you already doing that with that surgery? And so is extra PRP worth it? I don't know the data on that specifically. Yeah.
If you have tennis elbow, how long would you expect to see results from PRP? if you continue the activity, could you continue doing the same activity that's exacerbating the tennis elbow after you had PRP?
After you had the PRP and you rehab, yes. Yeah, and I've seen plenty of people who have had prolonged pain, multiple cortisone injections, physical therapy. I've had 1 or 2 PRP, and it is better, and it has not come back. Yeah, yeah, that's the best. The evidence behind that in my clinical outcomes for tennis elbow are the best.
So I've done the cortisone injection and I still play pickleball. My elbow's still not better.
Yeah.
So
Yeah, it would be the next step potentially. Yeah.
Just a follow-up to the question on the hip, so I have mild arthritis, no pain, but mobility issues. For the hips, is this something that could help the mobility as well?
Yeah, and it depends why the mobility issues are there. I guess.
So I do have some bone on bone.
Yeah, so if the mobility is because of the bone spurs, then the PRP is not going to help that. It could help associated pain, but if truly your pain was a mechanical restriction from the bone spurs, I would not expect PRP to improve your range of motion for that reason. Does that make sense?
Yes.
Yeah.
So assuming that Dr. Heaton or somebody has given you a PRP injection, what can you expect afterwards, and what might therapy do to kind of help with that complete healing process after the fact? And people, we've already been asked, right? Do you need therapy after a PRP injection? It really depends. As Dr. Heaton said, for more of the tendon issues, we definitely see a more favorable response if you then go through some therapy afterwards. For somebody who has a joint problem, it could be your shoulder, maybe you're a very active tennis player, still playing tennis, able to serve full range of motion, good strength. Pain is really just what's keeping you bothered. You may not need any therapy afterwards. If your range of motion is good and your strength is otherwise good, and this helps bring your pain down a little bit, you might not need therapy afterwards. Same thing with the hip or the knee. If you otherwise have good flexibility, you have good strength, and it's mostly a pain issue, you may not need therapy. Oftentimes, though, we do find that secondary to whether it be stiffness at a joint, sometimes when you don't use a joint normally for a period of time, it's not just the joint that gets stiff, it's the muscles around it that get stiff. So your hamstrings get tight, your quads get tight, or your rotator cuff gets tight because you haven't been able to lift your arm because of pain. And then once the injection goes in, it allows you to have full range of motion, but you don't have any strength up here because you haven't used it up here in a long time. So it's different for everybody. So some people will benefit from it. Some people may not need it at all. And then also biomechanics. A lot of times people change how they move, or they change how they run, the mechanics of running or walking, or their serve, maybe they can't go overhead. So they've kind of modified things. And now they're irritating parts of their shoulder, rotator cuff, because they've changed the mechanics of what they do. So we can help with that biomechanical kind of re-education of certain muscles or the right patterns to use, like either when you're walking or using your upper body, something like that. So that would be very activity specific depending upon what you do and what you want to get back to. So again, you can see either joint or muscle stiffness afterwards. We can address that. The weakness, when you have weakness, you also end up with sometimes joint instability. And that could be not just that your legs like stability and balance, but also instability of your shoulder where it's not working correctly. So we can help kind of build on that. And then compensations. If you've been avoiding one side, one knee versus another, you may be developing some issues on the opposite side, or you may have developed some, like I said, biomechanical changes on the bad side or the injured side. So we kind of help balance everything back out, so you're more symmetrical when you get back to your activities. So gradual return to activity is also something that is usually encouraged. Like Dr. Heaton said, every doctor's got their own protocol, but usually a gradual return to activity is better than just diving right back in. So if your knee's been bothering you for a long time, you're a big runner and you've been doing a lot of running and you get an injection the next day, you think you can go out run 10 miles. That might not be the best thing to do right after an injection. If you remember that one of the early pictures that Dr. Heaton showed, you're trying to allow things to kind of heal up in there, right? And kind of get more stable and kind of patched up. And if you go out and just pound it the very next day, you might sort of disrupt what's been going on in there. So again, if there's a specific protocol, we'll follow it. But otherwise, we usually recommend a gradual return to activity. Try to get that flexibility and strength back first, and then build back into more like sports, or if it's just walking or whatever the activities are. But usually gradual is the way to go. And a lot of times we recommend modified activities or or modified environment. So you can either change the environment that you work out in, right? Or you can change some of the variables in your workouts, right? Everybody knows what sets and reps and weights are for working out. Those are the things that you can change, you can adjust, you can modify to make sure that you're not putting too much stress on a certain joint, but also building it back up so that you can get back to whatever it is that you want to do. So some of the ways you can modify your environment, and this is specific for lower body. So if you've had a hip PRP injection or a knee PRP injection, once you're allowed, because once you've had an injection, it's still invasive to a degree. So you have to be careful that you get clearance to be in an aquatic environment. But aquatics is a great way to slowly reintroduce sort of weight-bearing activities to lower body, so hip, knee, ankle. You get the benefit of the buoyancy of the water, what they call hydrostatic pressure. So, you always hear about the bends, right? And so the lower you go in the water, the more pressure there is. So the deeper water that you're in, the more pressure you get on some of the lower parts of the body, and the more buoyant the water makes you. So when you're in water that's waist deep, you only weigh about 50% of what you weigh on land. So there's 50% less pressure on joints underwater because of your body weight. When you're in water up to your chest, you're only about a quarter of what you weigh on land. So you can really modify the environment. And then the warm water sometimes will just relax muscles, help with stiff joints and things like that. So aquatic therapy can be helpful. And now there's some new technology where we actually have one here. I know Dr. Heaton has seen some other places that have these. They're anti-gravity treadmills. Has anybody ever seen the one downstairs or heard of these? It's called an Alter G, this particular model that we have. That's the main one that's out and about. There's different practices that have them. But this uses air pressure. It was actually developed by NASA. And it uses air pressure in that sort of like vacuum in that space to sort of lift and unweight, again, the hips and knees. So you can be 80% non-weight bearing or only 20% of your actual body weight. So if you weigh 100 pounds and you put the max on, there's only 20 pounds worth of weight going through your joints. And the nice thing is because it's air, you don't have any resistance. So if you try to run in the water, has anybody ever tried to run in the water? Right? It's like you're running in quicksand, right? The nice thing about the Alter G is that it's just air. So it's over a treadmill and you can walk and run like you're running outside or walking outside. There's no resistance from that air pressure. It just kind of unweights you. So again, it's a way to kind of ease back into activity. So if you have, and again, as we said, if you're dealing with joints that are arthritic, and most people that are seeking out PRP injections for joints have some level of arthritis in there. So modifying the environment like this can help quite a bit. Same thing for upper body too. So when you want to work out your upper body, shoulders, back, chest, you can do things that are what we call closed chain, where you're putting weight through your hands or through your arms, right? But that puts a little bit more pressure on the joints, including the elbow and the shoulder. Or you can do things that are what we call more open chain, where the hand is moving and it still puts pressure on the joint, but it's less than if you're bearing weight through it. So again, this is what therapy can teach you, or even if you're just at the gym, just keeping these things in mind or asking the trainer about what you can do after a PRP injection. You may have to modify what you normally do to not irritate or aggravate what you've already kind of been working on and treating with the PRP injections. And then you can also try to do less load on the muscles. So again, if you have, let's say you're working on your elbow, right? The idea is not to go out the next day and see if you can irritate it as quickly as possible, right? So modify, lower the loads. Maybe don't do 3 sets of 15 at the heaviest weight you can possibly do. Maybe shorten up the number of reps, maybe shorten the number of sets, and think about lightening the load. One of the ways that's sort of a new technology of lightening loads that can be very helpful, and it's interesting that we talk about this here at Cedardale. This was developed in the fitness world, not in the therapy world. So this is called blood flow restriction therapy, and it uses a cuff, so kind of like a blood pressure cuff. And so you put it around part of the body. So where this is here on his thigh, the idea is he's restricting blood flow below it. So if you had a knee issue or an ankle issue or something like that, it's going to reduce the blood flow to an area below the cuff. And then you exercise, but the body fatigues much, much quicker at much lighter loads with blood flow restriction. The benefit is your body is tricked into thinking that you're doing a super heavy load of exercise, but you're not. So you can put less stress on, let's say, the knee joint or the ankle joint, but you fatigue as though you did a heavy squat day, for example. We had done we had done a whole education circuit or series actually right in this room a couple years ago. And this was pretty new to our organization. And we had one of our therapists was here. She's very fit, in shape. She's a runner. And we needed somebody to do a demo. So we said, oh, can you just do this? And she goes to the gym a lot. And we said, here, put this on. And she just did 10 body squats. And by the 9th one, you could see the strain, like she was working hard. Now, this is somebody who probably could normally go onto a squat rack and, rack her weight and have no problem. And by the second set, she was absolutely sweating and exhausted. So it doesn't take a lot of volume and it doesn't take a lot of resistance to get a really good workout. So it's a nice way to kind of ease back into it, get a good benefit of workout without stressing the joints. And then obviously we want to get back to very sports specific exercises. So this is where if you're getting back to, again, walking, running, tennis, whatever it is, eventually you want to make sure you have good mechanics, because if you're compensating, you're going to develop, if not the same issue, other issues in other parts of the body because you're cheating or compensating. But you also want to try to simulate what you're going to do when you get back to whatever the activity is. So we want to try to mimic certain things. So if your idea is to get back to doing weight-bearing activities, walking, running, tennis, whatever it is, doing a seated leg kick is not very, it doesn't really simulate anything that you're doing. But standing and doing some leg work with a band, you're putting weight through your body, which is what you're going to be doing when you're on your feet. So we usually encourage more weight-bearing activities for people that are active on their feet. Similarly, you can use a leg press. It works the muscles great. It's going to work on your quads, going to work on your glutes and your hamstrings. But it doesn't really simulate anything, right? When are you in that position doing that motion? Almost never. But oftentimes, and you get the same muscles working out here, but there's a very functional movement pattern. It's a ball squat. You could do a free squat. You could do a chair, sit to stand. It's a very functional movement. So we try to encourage more functional movements if that's what you're trying to get back to. And then similarly, static versus dynamic. When you're on the floor, it's very supportive. It's very static. It works the muscles well. That person doing a straight leg raise is going to work their quads and hip flexors just fine. This person's going to get the same workout, except now they're in a more functional position and they're having to balance on one leg. So they're working actually both legs. One's doing the kicking, one's doing the balancing. So again, when you get back to trying to do activities and maybe you've had a PRP injection and you're trying to return to activity, this is the kind of benefit you may get from doing physical therapy to kind of get you back into it. So it's very complementary oftentimes with these different types of PRP injections. So, but definitely consider the modified environment too. I think that's something that people make mistakes. We've seen it quite a few times where people just kind of go right back out and start hammering away. And then they say, wow, I'm still really sore. We're like, well, yeah, I didn't really ease back into it much at all. So do you have any protocols for like hips and knees right afterwards? You tend to have people kind of take any time off? Or...
We do. And so basically we don't even start like concentric exercises for 6 weeks.
Yeah.
So after PRP, I say like the first week is just like, it's pro-inflammatory. So you might have some increased discomfort. So the first week is like, do nothing. Second and third week is like, just work on range of motion in that joint or tendon that was used. And then starting about 3 to 4 weeks is where you might start some like isometric stuff and like just easy stuff. And then, but like, it's usually like 6 weeks until you're really doing like more, more significant, because I tell people after PRP, I'm like, imagine me giving you a new partial thickness tear in your rotator cuff. And I want it to heal this time. So I'm putting extra platelets in it. Would you go out and do heavy lifting after you just partially tore your rotator cuff in 2 weeks? No way you would. We would be telling you, no, it's at least 4 to 6 weeks before you should be doing any lifting. That's got to heal, right? So I use the same timeline almost as if it's a new tendon injury, a partial thickness tear. That's my timeline wise, how I would think about it. Yeah.
So it's not a magic pill, not a silver bullet. You still have to kind of ease back into everything. I think some people have a misconception of that too, is they think it's like, oh, well, I had this done. I'm good to go.
Yeah.
I'm going to go run tomorrow. So.
What about if you have some atrophy, unexplained atrophy, and then you would PRP be beneficial? Plus, PT, I would assume. I mean, I got a VMO that's significantly smaller than the other one. I ride a bike. I've been riding a bike for 5 years, and now I'm having a knee pain. They say, oh, your patellar's offline. I don't have arthritis, but it hurts.
Yeah, I guess the answer to that is directly, would it increase the muscle mass there? No. So you'd have to figure out really why do you have atrophy there? So is there some biomechanical issue that's going on? But I wouldn't think that, oh, me doing an injection into your knee is going to improve the strengthening of that. There's got to be some other reason.